Interventional radiology, as I was saying, is very diverse in terms of the organ systems that we will work in. And at the same time, we all kind of have our little subspecialties that we tend to like a little more. You know, certain organ systems, for whatever reason, we tend to be a little bit more agile within because we've done maybe a few more of this particular subset of, of procedures. And I do recall we all have our mentors. Go back, and there was one staff interventionalist at the Cleveland Clinic where I did my fellowship that was just particularly good in doing a lot of the GU or kidney kind of work, as well as liver, biliary work. And for whatever reason, I just kind of followed him around and did his techniques, and I have now a similar passion for these two areas. And it's amazing, again, we've talked about how technology has changed. We do a lot of things within the liver that we really couldn't do before. Now we're talking about biopsies. When we find tumor, can we basically treat the tumor? We're now doing more in terms of real therapies, where if we have a localized tumor, we can treat that just by, using CAT scan and putting a small needle into that area where the tumor is and ablating or killing the tumor very locally. We can do either cryoablation, which means a freezing of the tumor, or we can do a radiofrequency ablation, which means actually burning the tumor, but very, very focally. And again, without the imaging, we would not be able to localize that tumor and actually just pick that tumor out. And it's very important because now we're looking at either partial hepatectomies or even liver transplants, and patients will be not considered for a transplant, not considered for a resection because they have too many tumors. Now, if we can ablate a couple of those tumors, now they're suddenly in the surgical candidate, a surgical candidate to have a procedure. So it completely changes their staging, or we go from 2 small lesions to no lesions, and now they're cured. So the whole cryo and radiofrequency ablation has truly kind of evolutionized our treatment. And there's other patients who have more diffuse disease that we're now treating by going into the artery and doing what's called chemoembolization. When you give chemotherapy, and almost everybody's familiar with that, putting it in the vein and people get sick, their hair falls out depending on the agent used, well, we can avoid a lot of those systemic, broad kind of effects to the patient by actually going into the artery and delivering the medicine right into the liver where the tumor is. So that's local therapy, and quite frankly, some of the outcomes for that have been more effective than giving traditional chemotherapy, through the vein or through a port or a central line kind of thing. So once again, the whole liver treatment has changed considerably. One of the other things that, again, another sort of passion of mine, and I have no idea why, but I do a lot of biliary work where people have problems with the bile ducts. The liver makes bile, and the bile comes together and in a tree-like fashion through all the branches and comes down a common trunk to go into the small bowel. It's what colors our stool, brown and that kind of thing, and helps with digestion. And people sometimes get blockages of that bile duct from tumor, sometimes even benign entities. And we can go in through the liver and kind of help open those bile ducts up. Another thing that we do not infrequently. Another thing in the liver that we see more and more of too are people who have cirrhosis. These people can have a terrible problem with throwing up blood, sometimes just a lot of fluid on the belly, and we can actually go into the neck, into the liver, make a new pathway in the liver, such takes the pressure off of blocked veins that are coming into this scarred liver. And patients do much better with that. Patients, can go on to function more normally. And it's kind of a complex procedure. It's called TIPS, and it's called transjugular intrahepatic portosystemic shunt. What does that mean? It just means you're making a new pathway in the liver, and we're doing that all with a small IV in the neck. That's the only mark we'll make on a patient. We can go into the liver, make a new pathway, connect different veins, kind of reroute things and patients can do really very well with that. I mean, there are some patients that the procedure we're going to do is more palliation. Sometimes when you have blocked bile ducts, it can, you're all yellow, and sometimes the bile salts are actually deposited in the skin and have just horrific itching, and it can be terribly uncomfortable. And we can actually have that bile go elsewhere such that they're not all yellow anymore, it's not going to the skin anymore, and they're more comfortable. That is not a curative procedure. Now we talk about cryoablation, radiofrequency ablation, that's a different ballgame. Or the chemoembolization, a different ballgame. People that are non-surgical candidates, either you can basically cure them that way, or take them from a non-surgical patient and now make them surgical so they can go on to a complete cure. So that does kind of change their whole pathway. Whereas other patients, sometimes we are doing things to kind of just make them more comfortable, and it makes a big difference in them too.